Well, now we're going to have what might be a highlight of the meeting. And I don't know how we could top some of the sessions we've already had, but everybody's wondering, how will we pay for interventions that may be expensive or not? If it's metformin, that might be a no-brainer. But if it has to be a combination of different therapies, perhaps an app to prevent many different diseases, there will be the question about economics and other questions, which we'll be getting into later, even the ethics of being able to modify the lifespan, the healthiness of people. So this session, and I'd ask Gillian Leng to come up. Dr. Jill Leng is Deputy Director of the, or Deputy Chief Executive. And take a seat. Jill, it's great to have you. NICE, as everyone knows, is probably the most, let's say, innovative and well-known pharmacoeconomic evaluating organization. It's really the original in the sense that it has really put the metal to the pedal, or pedal to the metal, I guess it is, in making these very incisive kinds of determinations. Barry Straube, Dr. Barry Straube, come on up, and Barry and Jill are going to have a discussion that will be free-flowing, but Barry is, as much as could be, a counterpart of Jill's, in that he was the Chief Medical Officer of the Center for Medicaid and Medicare Services, which is more or less an analog in some ways. It also actually pays the money as well as decides how to pay it. But I think in a number of ways, Jill and Barry are similar in their roles of applying the intellectual product of their organizations to making decisions about how medical care will be funded. So we are privileged to have both of you today, and we would just have you get started.
Okay, thank you. Should you?
Yeah, well, Jill and I are just meeting, so Jill, nice to meet you.
Hello.
And we were asked, maybe perhaps Zan and Thomas had a premonition that there might be audiovisual problems, because we were asked to have a conversation just to kind of break things up. Okay, the volume's down. And what I thought, Jill, maybe we could start out, a preliminary comment. I found it interesting. I had the luxury of being here yesterday and was able to listen to the speakers. It was spectacular. I wish you could have been here.
Yeah.
But I think for the audience, what we might frame here is be thinking about what we're talking about for our respective national health systems, if you will, and how does the information that's been presented here so far fit in with, first, being operationalized and implemented into a delivery system in our respective countries. And then two, very importantly, as Zan was pointing out, what are the implications in terms of covering and paying or not for these various things we've been talking about. The prior discussion about the aging trial, I don't know if you had the same reaction, Jill, I did, but it was, there were all sorts of red flags and or questions going up in addition to what you've encountered and most people in this room with FDA. And I'll be more specific about what I'm talking about, and maybe we can help you with making sure that you don't end up with an FDA-approved drug that isn't going to be paid for. That's always the risk in the U.S. System, and probably in the British too. So maybe, Jill, the first thing if I could ask you, this is unscripted on there, but I'm sure you can handle this, would be, why don't we talk a little about, since we were talking about implications to health systems, we describe very quickly what our respective health system entails.
Yeah, that's a really good place to start, and it's a shame I wasn't here yesterday, but I've caught this morning's session. And in terms of what NICE's role is in relation to the health system, we clearly start with an evidence base, some of which comes from manufacturers and pharmaceutical companies, some of which comes from other sources of research evidence. We then go through a process of developing guidance where we assess that evidence independently and look, and here's the difficult bit, we look at value for money. Lots of different ways, lots of detailed methodologies around that, but that's key. We then make recommendations for the health service, and the most challenging bit is making change happen on the back of that, particularly as our health system at the moment is somewhat financially challenged. You might say, well, when hasn't a health system been financially challenged? But it is rather tight at the moment. I do just want to say, though, because based on the introduction and perhaps what you've heard, you might think that NICE is all about drugs. But we're absolutely not all about drugs. That's a key part of what we do. But we have a public health program. So the previous discussion around interventions, digital mechanisms for encouraging behaviour change, all of that is core to NICE's remit as well, and we've issued quite a lot of guidance around prevention. We look at new drugs, but we also look at all sorts of new technologies and med tech as well, including now some digital technologies, and there's a whole conversation I think we could have around digital. But we also look at social care. So you probably, if you're not in the UK, you probably think we've got a national health service that's publicly funded, which of course we do have, but that national funding doesn't apply to social care. So anything that happens in our system that means we live longer and require care, often at older stages of life, but not always, that isn't nationally funded. About half of it people pay for privately, and the other half, through a means-tested system, is funded through the state. But looking at the economics of that part of healthcare is quite a challenge, and we're doing our best to integrate it, but without the government saying we're going to state fund all social care, it's quite a big challenge to get that balance right. So that's rather a long introduction to how our health system works. But just to say that NICE guidance does make a big difference in a system where money is tight. It's not true, unfortunately, it's not true to say that anything NICE recommends is automatically going to happen. But it does tend to work the other way, that if NICE hasn't recommended it, or if NICE has said no, it's very unlikely to be funded in the health system. So we do have quite a lot of responsibility for making the right decision.
So that's juxtaposed very substantially with the U.S. system. If one wants to call it a system, it is a system, but it's not always running very well. I would describe our system as being a combination of systems. You know, I worked for CMS, and we ran the Medicare program, which most of you probably know. That's for age 65 and older, it's for the disabled, and it's for patients with end-stage renal disease. That's my specialty background. Then we have the Medicaid program, which is for low-income individuals, administered by the states, although overseen at the federal level by CMS and other agencies. And then finally we have the commercial system, which can entail all of the above, but is primarily, again, people under the age of 65 and all the way down to infancy, and it's funded by private health insurance premiums and employer contributions primarily. So I think that in listening to yesterday's presentations and now today, one of the things that comes out of this, at least in the U.S. system, and you might comment on the UK system, but it is so complex where you've got commercial, Medicare, and Medicaid plans, and in some cases on a state level or local level, et cetera, that are making the decisions we're going to be talking about. So trying to get Metabesity principles and interventions and whatnot into that kind of a complicated system is extremely difficult, and I can attest to that since I tried to do that for 11 years.
It's certainly less complex here. As I say, the implementation challenge, the challenge is nice saying, this is good value for money, this is best practice, do it. It certainly doesn't happen just at the click of a finger, but it is more straightforward. National guidance for a national system, and NICE has covered things like diabetes prevention, so we now have a diabetes prevention program that's been rolled out across the UK and being evaluated as well. And we have bits of NICE guidance. We don't have a single overarching, here's the metabolic syndrome guidance that picks up all the various elements that have been discussed this morning, but we do have guidance that covers all of those areas, and we do our best to track how well they're being followed. But there is an interesting debate that occurred to me while I was listening this morning, and it's very much a debate that comes from our primary care doctors, which is the prevention versus the, as they would describe it, mass medication agenda. And there's a lot of pushback from guidelines where we've recommended statins for quite a lot of the population, if they want to take it, of course. Recent guidance around managing type 2 diabetes and type 2 diabetes prevention and medication for those conditions is being quite hotly resisted by some parts of general practice, and that debate is an important one. And at the moment, we are channeling the response to that through something I've not heard mentioned, but it's about shared decision making. So here's the evidence says these drugs probably help versus it's mass medication, to really, really have to focus on the patient deciding at the end of the day. And we're doing a lot around developing shared decision aids, patient decision aids that demonstrate the risk and the benefits as we know it now, and helping the patients to engage in this conversation, which is really one for society, I would suggest.
So you've been speaking about programs that are being implemented to try to address metabolic syndrome and metabesity issues, and we were, I don't know if you feel that how effective they've been so far. Do you have any knowledge about that or any evidence to comment on? Are they working?
I don't have any evidence that has come out of the diabetes prevention program, other than perhaps the uptake levels are less than we had thought they would be, but that might change over time if the outcomes improve. The element that relates to benefits of treating people with type 2 diabetes, and I think particularly around the metformin question, that's something else that's coming back from the primary care community. They are telling me, and this is anecdotal, but they are telling me that they don't think they're seeing the benefits that we would have expected. That's fine, that's important, but we've got quite a few randomized controlled trials that have suggested there should be benefits. And I am very much hoping that we can get some, if you like, some real-world evidence back from primary care that is showing what is happening in practice, because we can do all the randomized controlled trials we like, can't we? But they tend to be in specific populations, and getting real-world evidence is very important, and that, for me, is one of the things that we need to do next, and we need to make sure in developing NICE guidance, NICE recommendations for the system, that we're using real-world evidence in a way that we haven't in the past.
Well, on the U.S. side, I think there's a lot of activity that's been ongoing for several years now in terms of targeting metabolic syndrome in particular, and the Metabesity term here, that was an advantage of my being here yesterday. Zan, I at first thought, as others have expressed, gee, what the heck is Metabesity? But I get it. I got it after the first couple of hours. And indeed, I think it's a pretty good term, actually. We just need to get people generally to understand it better.
You need to get it in Google.
In Google, yeah.
You can Google most things, can't you? You can find out what it means, but Metabesity doesn't come up very well.
But in the U.S., what I think this is an example of, for an action item in terms of how this community can get more things done. The Affordable Care Act, popularly known as Obamacare in the United States, passed in 2010. I was the chief medical officer at the time, and we were implementing that law. There was a very interesting precedent that had been set up in an earlier law called the Medicare Improvements for Patients and Provider Act that allowed or actually forced the Secretary of HHS to offer and implement preventive services using the U.S. Preventative Service Task Force as the arbitrator of the quality of evidence and what would qualify, therefore, for Medicare coverage. So there were a number of preventive services that got added to the Medicare portfolio because of that particular law. And what the Affordable Care Act did, which is, again, important to this community, was to specify a number of additional areas that had to be covered and dealt with not only by Medicare, but by the commercial health plans and all health plans in the United States. And that included a diabetes prevention program, and it included obesity screening and obesity counseling. So as a consequence of that, I think we've seen over the last 5 to 6 years, pretty much every health plan has some kind of program so they can qualify for that mandate that they have to have this kind of coverage. Some are better than others. I think some are not, they're more marketing tools, and I'm not sure that the outcomes are being affected. But some have been very effective, in those that are critically collecting data. And they tend to be modeled on the chronic care model and disease management kind of models. They incorporate a large amount of patient self-management. They redesign office practices to have patient flow-through be able to include obesity prevention techniques. They use decision support in the electronic health records that we're gradually adopting in the U.S. The clinical information systems have been upgraded by vendors to include some of the things that people have talked about here, but they need to go a long way after that. There's been telehealth and telemedicine. We just heard some discussion about that that's been incorporated into these programs. And then I think that as we've switched to a value-based purchasing, so-called reimbursement system in the United States, where people get rewarded theoretically for improvement in outcomes and also get rewarded if they can reduce costs, the practices are restructuring to try to promote those two goals ultimately. And then I'll end on my piece with I think that community resources are extremely important. And so practitioners are encouraged to partner, if you will, with communities, not just relying on federal or state or commercial health plan dollars to try to address this obesity screening, obesity prevention, and diabetes prevention, generally speaking.
It's interesting what you were saying about incentives for individuals to improve their health, because we don't have that mechanism at all. I'm just trying to think, am I correct in saying we don't have it at all? I don't think we've had any incentives for individuals to improve their health, other than once when NICE recommended vouchers for people who'd been addicted to hardcore drugs for staying clean. And that was a research study from the US, and we recommended giving vouchers to people as an incentive to look after their health. And it was extremely controversial. I think there was a pilot, and I don't think it got rolled out. The closest we have is incentives for our doctors, our clinicians, to improve the health of their patients. It has to happen that way round, which is effective to a degree, but it's certainly not the same as how you might go about changing individual behaviour. So we have lots of focus at the moment on obesity, the obesity epidemic, and how we might address that with various strands of activity, from sort of environmental changes, but more focusing on how do you get individuals to change their behaviour, which lets me segue, I hope, neatly into the digital technologies, because I thought the previous presentation was really great. It was really interesting, and there's lots of hope at the moment that getting the public to use an app or a Fitbit or some such technology is going to radically change the health of the population. And the question for us at NICE is, how much do you have to evaluate those technologies? How much do you have to regulate them? And we haven't come yet to a clear conclusion, but I don't think anybody else has either, on how you best evaluate apps or other digital technologies. Clearly, it has to be commensurate with the risk, because if it's low risk, we probably won't bother, will we? But if it's something that's higher risk, and if it's something we want the health system to pay for, then it becomes more important to have the evidence base, doesn't it? And it would be great to know what the evidence base is behind the VIDA system that we just heard, because if there's something that looks like it makes significant changes to the health of the population that are sustained, and our health system wanted to pay for it, then we would need to evaluate it and look at the value for money argument. And you know, there is limited good evidence at the moment from the apps that we've looked at, and I hear bits of information. For instance, the fact that you are encouraging people to track the amount of exercise they're taking should be a good thing, shouldn't it? It should improve people's ability to lose weight by focusing on how much exercise they're taking. But the one randomized controlled trial certainly shows the opposite. And it seems to be that the more people feel they're doing in terms of exercise, the more they can eat, and they're actually putting on weight. So we can't just assume, even however plausible these things are, we can't make assumptions about the benefits of digital technologies. And I'll stop in a minute, but there's another sort of rather depressing example of using digital technology to measure how breathless people are with heart failure. And the idea was you would intervene early and prevent admissions to hospital. But again, it had the converse. By raising anxiety about being slightly more breathless, you get more interaction with the health service, who takes a low-risk approach and says you need to come in and be checked. And you actually get an increase in admissions rather than a decrease. So just I don't want it to be a note of caution, but because we have to be commensurate with the evidence base and the risk and the ability for the population to benefit, but we do need to make sure we can demonstrate the impact, so our health systems fund fund appropriately.
Yes, Suzanne.
This is great, Barry and Jill. Evidence, of course, is key here, and it's important for Jill to remind us that we can't just assume what is logical. Let's assume that we're going to have evidence from TAME. Nir and Steve have presented this trial. It's truly a Metabesity trial. It's not representative of the general population, certainly, but it's a form of going after multi-disease prevention, in a sense. So let's assume the evidence is positive. You have more or less a consistent effect across these components of the composite. I'm not sure how MHRA and FDA will form a label for that indication, but let's just assume there is an indication of some kind. What do you do with that? What's NICE going to do with that? And Barry, what do you think CMS will do with it?
Well, you want to start?
Well, NICE looks at drugs in two ways, and usually things that have got new indications come through our technology appraisal program, which is where we do an in-depth review of the evidence and the cost effectiveness. And it's probable that that's what would happen in relation to this, and if it did, we would take a view on whether it was good value for money. We'd have to take into account some of the costs around putting it into practice and what the benefits to the population might be. But if we recommended it, that would then mean that the health system had to pay for it if a clinician wanted to use it. I think it's probably more complicated, though, because it's a program. You'd have to set up a mechanism for identifying appropriate patients, and you'd have to think about all the implementation challenges. But just to say, I said two ways, so I want to just complete what I said, because there's the formal technology appraisal program, but we also have guidelines on prevention and on various diseases and conditions, and it might be deemed more appropriate to be wrapped up in one of those prevention type guidelines, because we could then look at it in amongst a whole range of other interventions and take a view on what might work best for our health system. And without seeing any more detail, I can't give you a judgment, of course. But that's how it would be, and the decision would be based entirely on the evidence of effectiveness and cost effectiveness. But I suspect the challenge would be one of implementation.
So on the Medicare side, very, very different. A couple of caveats that, again, may be helpful to Nir and to Steve in their study. One, in the U.S., if a device or a drug or a treatment is subject to FDA review, the first thing would be to get FDA approval, which is what they're after.
I was assuming that it got a license.
Yes, although a lot of what's been discussed here in the last day and a half doesn't need FDA approval. So what I'm about to say still applies, and that is if it comes over to CMS having had FDA approval, or if it doesn't need FDA approval, one, it has to be a benefit category that Medicare covers. And that's one area where it gets a little tricky. Eyeglasses, for instance, are not covered under Medicare. So that would be something that if it came to CMS and FDA approved some special eyeglass for some reason, it wouldn't be covered because it's against the law to cover it under current law. Once it comes to CMS, CMS uses a different standard and authorization than FDA. It has to determine if the treatment service drug is reasonable and necessary. And there's some statutory language behind that, as opposed to FDA's safe and effective for marketing purposes. So there is the possibility sometimes that the two agencies could come to different determinations. It could be FDA approved, but CMS could say, by our standards and our evidentiary criteria, it doesn't qualify for coverage. That has rarely, if ever, happened, but it has delayed things. So that one piece of advice I always give is for people to go in and meet with CMS simultaneous. We started a parallel review process while I was there, where people could talk to us in a pilot project. It was for medical technology only, and it didn't gain much popularity, although they're still trying to revamp that. So, but putting that aside, going in to talk to CMS on any of the treatments that we've heard about in the last day and a half, to say, what are your evidentiary criteria? How do you want to set up a clinical trial for your purposes, which are different than than FDA can be very instructive and avoid down the line having done work only to be told that it doesn't satisfy the payer in this case. And then the other caveat, which is interesting right now, because you've mentioned cost-effective analysis. Although many of us have been proponents of that for decades, this country is very slow to include cost. And in fact, the current interpretation at CMS is that cost cannot be taken into account for coverage decision-making. If it meets the evidentiary standards for being reasonable and necessary, it has to be approved regardless of its cost. So the last thing that I'll say in answer to Zan's would be, and we get to another topic of yesterday, and that is there are exclusions that create a problem, and the weight reduction drugs was an example of that. That was specifically in legislation prohibited from CMS for paying for weight loss drugs. It was the way the statute read. So when Qsymia and some of the other newer drugs came out, this is an example of FDA approval, but CMS wouldn't pay for those, and many of the commercial payers wouldn't pay for it either. So on the aging thing, my first take on that is that that's an area I think that it would be excellent to clarify whether or not an anti-aging drug, if it's problematic for anybody, because I don't remember that that's anywhere in statute or whatnot. I wouldn't think it should be, but particularly if you propose it as a preventive, it's going to prevent other things. And that's where I was surprised recently CMS didn't take that tack with the weight loss drugs to try to say they have other properties that might lower lipids, or they might treat cardiovascular disease or other things, and kind of go the back door there.
That leads to the question I was going to ask. Is there doomsday planning going on for pharma, despite 13 failed phase 3 trials, is going after Alzheimer's with a high-priced recombinant monoclonal antibody